This station has quite a few objectives. If you looked over there, obviously not very feasible to talk about them all. We will try to bring up the most important difference in between these two particular machines, which relates to the contribution of the fresh gas flow to the set tidal volume, therefore the delivered tidal volume is different, and where this tidal volume discrepancies do come from. And as I said, the difference in between the older and the newer dragger machine, which have the fresh, the decoupling valve that kind of takes out the contribution of the fresh gas flow to the set tidal volume. Therefore, you get a very accurate tidal volume, which is important in patients with abnormal lung compliance, which is important in pediatric population. And also your final sampling of the delivered tidal volume is going to be better because there is no such contribution.
Yes. So what we can show you is on the, this is a Narcomed GS anesthesia machine. And so
feel free to come closer so that
yeah.
you can have a better look at it.
When I turn on a liter of flow on this machine, I've got a frequency of 10, I 1 to 2. My inspiratory flow is high enough to deliver the volume that I've got set in. When I select the selector valve over to auto mode, my breathing bag is now out of the system. Okay, and now my ventilator will start, and I've got set about 600 for a tidal volume. And so with the 1 liter gas flow, I can look up and see what my tidal volume is. Okay, now this machine does not compensate for compliance, and it doesn't compensate for fresh gas flow. So as I turn this up to, let's say, 8 liters of flow, which is typical of an induction, right? You're going to give them 8 liters of flow, pre-oxygenate, and you can see that my tidal volume is significantly higher than what I would maybe have expected to see here. Okay, so this is out of the circuit. Our fresh gas obviously affects tidal volume, and so that's what we're trying to show here. And Michael Jr. is going to go over the numbers in a minute. Now, what I'm going to do is just show you on this machine now the difference. So when I turn this machine on, and I'll put on about a liter of flow. And I'll put on volume control mode. And I'll get a pressure waveform down here. And my tidal volume will be up on top. So one thing you'll notice that while I'm in volume control mode, this breathing bag is still moving, right? So it's still part of the system. This is where fresh gas decoupling comes into this type of an anesthesia machine. Whereas that machine's fresh gas flow went into the breathing system directly during the entire phase, inspiratory phase, expiratory phase, it's always being added in. This machine does not. So during the inspiratory stroke of our ventilation, you can see that this bag will move. That fresh gas flow is being held in there while the piston is delivering your set tidal volume. Okay, and I'm going to show you that as I 575, as I increase my flow, it really has no effect on my tidal volume delivery. Okay, another difference in this machine is that it's also compliance compensating. So when you did your leak test over there, you got a compliance number, a value. This machine uses that compliance value to more accurately deliver tidal volume, and it's taking into consideration what are we losing in compliance. Okay. So that's one of the, I guess, the differences. The other difference in this type of an anesthesia machine, especially the Apollo, is it takes a sample of gas for analysis for CO2 and agent, right? That's about a 200 cc drop. It samples it, reads it, displays it, but then it puts that back into this breathing system. On that machine, there's a gas analyzer separate. It samples that 200 cc's, but it takes it to the scavenger afterwards. So we're losing 200 cc's there as well. Okay. You got to remember that when you're looking at all these things have tolerances. So the flow on here is plus or minus 5%. The flow tubes on there are plus or minus 6%. You know, our sensors for volume and pressure, they all have tolerances. So they're not just a set number and it has to be that. There is a plus or minus to all this stuff. I'm going to turn the flow down just to conserve on gas because we're running off an E-cylinder. One of the other things we want to show is alarms, okay? So we have pressure alarms built into these machines, right, to help monitor our breathing pressures. So in this machine, we have a peak airway pressure, and I'm going to go down to the peak airway pressure alarm, and I'm going to bring it down so that I will achieve a pressure alarm, okay? So now I've got my high airway pressure alarm. So that can be adjusted, so if you do hit a peak airway alarm, you may be able to increase that, or you may have to do something different to ventilate your patient in order not to be hitting that peak airway pressure. Another alarm you can get in this system is pressure limit. So you may see both of those come up, a pressure limiting, and I've got a peak airway pressure alarm. So you've got two things going on. Number one, I can't deliver my set tidal volume because I'm pressure limited, and number two, my peak airway pressure is too low.
So certainly at that point there's a decrease in lung compliance. That's related to what's going on in the case. If the patient is under light anesthesia, you may need to administer more muscle relaxant. Surgeons are doing something, packing the abdomen, pushing lungs up. You change position from supine to deliver, and that may change lung compliance. So all those things would have to be taken into consideration. Once you silence the alarm, you'll have to do something about it. And the idea is that you don't want to continue to maintain high peak airway pressures, number one. Number two, you cannot deliver the set tidal volume, so you may end up hypoventilating that patient.
Yep. So we also have the apnea pressure alarm. So that apnea pressure alarm is that dashed line that we see across the screen. Typically its default is 8 centimeters of water pressure. I've moved it up in order to achieve an alarm situation, and you can see we have our apnea pressure. We have to, when the ventilator is on, our pressure waveform has to cross that threshold every 15 seconds or we'll get an apnea pressure alarm. So typically at the end of a case you might see that when you're waking your patient up and you're not creating that pressure anymore, then all of a sudden you're getting this alarm. Why is it alarming? Well, we don't have any pressures going on. But really what it's designed to do is to alert you of a situation where you're losing pressure. So it might not be a complete disconnect where, I was at 20 and now I'm at 0. It might be that, maybe your endotracheal tube, the cuff has developed a 1 centimeter leak. So every breath, you're losing 1 centimeter water pressure. Well, if you have this set at 16 and you are ventilating at 20, within 4 breaths you're going to get your first alarm. So you might be sitting there for an hour, everything's been fine, all of a sudden you've developed a leak for some reason. Something happened during the case to change the position of that tube or whatever, and you develop a leak. Well, you get an apnea pressure alarm, and then the next breath you say, oh, I was at 19, now I'm at 18, then I'm at 17. Well, you've got to correct the situation because we're going in the wrong direction here. So that's really what that alarm is designed to do. Another thing you can do is get a continuing airway pressure alarm. That's typically maybe when you've intubated and you've got the APL valve closed, right? And the system fills up with gas. I want to adjust my alarm down a little bit. So you can see what happens. We've built pressure, and now we've stayed above our apnea pressure line, that 8 or whatever you've got it set at, for more than 15 seconds. And then we'll get continuing pressure, okay? So that's something you want to be very concerned with.
That's one situation you want to keep in mind when you use the oxygen flush valve. When the APL is closed or during respiratory phase, you will end up generating a lot of pressure in the lung and pushing high flow, so that can generate
So this valve, you could open it or you can just lift on it to dump pressure, either way. Okay.
Negative pressure alarm or subatmospheric pressure is another pressure that you may hear on these machines, when obviously you have less than 10 centimeter water pressure, or that when the patients end up breathing in from an empty bag, then you generate negative pressure because there's nothing to breathe upon.
Okay, and then we'll go back to volume control. And what we're going to show you with volume control is a typical looking waveform for a volume control pressure waveform. So there it is. We're ramping up our pressure, we hit our peak, and then we get a plateau. Okay, now I can emphasize the plateau probably. That's not the one.
So this is one of the keywords, different patterns of flow associated with different modes of ventilation. So most likely the question is going to present itself as a particular flow pattern that you would have to associate it with a mode of ventilation. So we showed you volume control. So basically,
Yep, this is volume control.
the volume is the same breath per breath, but the inspiratory pressure might differ.
Right, and then we'll go to straight pressure control. So this will be another volume control breath, and then the next one will be a pressure control breath. See the difference?
So the pattern it's completely different. The breath is going to stop being delivered when that pressure is attained, regardless if a certain tidal volume has been delivered or not.
Right. Okay, and then another mode we have is pressure support. So the first two, volume and pressure, were modes where we're going to set a rate for our patient, but in pressure support, they're going to set their own rate, and we're just going to monitor it, right? So I'll breathe for the patient over here. You'll see I get a vertical line on an initiated breath. Okay, so you really need to look at this graph here to get a better understanding of what's going on
So
a
here,
triggered
all the
breath.
dips basically are patient-initiated breath, either if it's pressure support or it's SIMV. It's followed by, in the pressure support mode, you're going to have the additional delivered tidal volume depending on how many centimeters of water you have. But that's kind of the difference in between control modes of ventilation and modes of ventilation that the patient would initiate the breath. You would have the dip here, and then you will be able to differentiate in between this modes of ventilation, either volume or pressure control.
Yep, so now if I go back to volume control, I can have straight volume control, straight pressure control, or I can add sync, which would make it synchronized intermittent mandatory ventilation, SIMV, and I can have pressure support in there. So you can do a lot within a mode. So you can have a mandatory mode with a support mode in there, and then adding PEEP as well.
Right. So if you add PEEP, basically the baseline is going to be lifted up with 5, 8, 10 centimeters of water, whatever you end up adding.
Can I ask, how did you sync that?
What do you want to say?
How did you
Sync?
How did you sync it? Yeah.
So we go to extra settings and turn the trigger off. And now it's just a straight volume control ventilator. If I want to add sync, what I got to do is turn on a trigger. So in order to do that, I go to extra settings, trigger. 2 liters is pretty common for most adult patients. So that's a pretty normal. If you would get auto triggering, trigger, that would tell you that you're too sensitive. That's a sensitivity setting. So you could adjust this to be less sensitive and bring up your trigger up a little bit higher.
So it's
go ahead.
Thanks.
Is it basically identifying since you're in volume control? It's identifying like a patient.
effort.
Okay.
And then
Exactly right.
Since you're in volume
So it doesn't-
control, it's going to deliver tidal set volume, or is there?
It's going to trigger the ventilator so that if you've got a set rate, like, and there's a window of opportunity, so when that patient would take a breath, and initiate a breath, the ventilator will just cycle with that, so the patient won't fight the ventilator. So it's
like
like a
you're saying.
weaning.
It's not giving you an inspiratory when the patient's exhaling.
Yeah.
Right.
It
Exactly.
waits still a percentage of your expiratory phase, and then it gives that inspiratory breath. It waits till you're about 25% finished, and then it gives you a breath. So it allows you synchronizing. But when you, what Dave showed you about that is that if you were to turn your trigger off, and then you go, if you just set pressure support, because the definition of pressure support is it augments your spontaneous tidal volume. If you go into pressure support and turn it on, it automatically sets the trigger.
Right.
Because you have to have a trigger because it's you have to trigger it spontaneously.
Yeah.
So it automatically turns the trigger on. So most people, it's a good habit to get into to use pressure support anyways at some level because 5 centimeters of water pressure is just about is a little bit more than 2 compensation for the ET tube. So you always feel safe with that. So if you just set your pressure support on this initial screen, it automatically turns the sync on. So that's a nice way I think on this machine to do that.
So we'll move through those calculations.
For the apnea, pressure alarm. So you said that a lot. I've seen it a lot when you're waking up.
Yep.
You're like turning down.
You have the same machines?
Yep.
Right, because initially they are not going to breathe, right? And then they pick up breathing. So by the time they are breathing, they have to breathe every 15 seconds. So if they do not breathe, there's no breath initiation every 15 seconds. The alarm is not being forced. The patient may not necessarily be apneic, may choose to assist or, put them on pressure support may not be enough
Right,
because
so
we're
I've
still
seen
going
where
to.
I've been assisting, and then it's just annoying. Like, how do you change? Can you change?
Because again, you're like past 15 seconds. And
You really
don't
can't
get a breath
you cannot
for 15
disable
seconds,
it,
yes.
right? Yeah. Now, when you go out of vent mode and you're in spontaneous mode, then your timing on that goes from 15 seconds to 30. So every 30 seconds you have to cross that. But you can't just disable it.
Yeah.
You can turn it down.
These are all safety features.
Right.
If you think about all these
Right.
alarms. So we press them down because they're annoying, but then the next thing in the next 2 seconds is to do something about it and check what's the problem.
Well, yeah.
Well, if you're about to leave the room and the patient is extubating and breathing fine, you could care less about the apnea pressure alarm. But in any other conditions, it's a very important one.
Yep.
So we'll move on to the math station there.
The math station.
That's Mr. Wizard with the math.
It's all about getting some
We
reason
wait,
into
we wait to the end to
uh,
do the
coupling
calculations,
and
so
the
it should be
decoupling.
reversed, right? I said earlier I should have like a talking chicken. I do this to make it more interesting. But Dave eloquently explained the difference between the bellows non-fresh gas flow decoupled machine and the piston-driven fresh gas flow decoupled machine. So the fresh gas flow decoupled, now that you went to a piston-driven system, you no longer have a bellows, which is a reservoir. This was the de facto reservoir for your patient. We now use the bag, the breathing bag, the manual ventilation bag, as your new reservoir, right? So that's where the fresh gas flow gets decoupled too. With that, so why did we do that? Why did we transition this Draeger machine to the kind that's a piston-driven fresh gas flow decoupled? And a lot of it's for accuracy of ventilation. And we want you to just think as we go through this, all the factors I'm going to talk about and how it affects your tidal volume to the patient. If you have a fresh gas flow of 8 liters a minute, that comes out to 133 mLs per second, right? And we'll get back to that in a split second. If you have a rate of 10, that's 1 breath every 6 seconds. If you have an I ratio of 1 to 2, 2 seconds of it is I and 4 seconds is E out of that 6 seconds, right? So with a tidal volume of 600 on the bellows non-fresh gas flow decoupled machine at 8 liters a minute when you start the case or when your patient has trouble, so the time when you want to turn on the oxygen, you're going to add 266. That's 133 times 2 because you're in I for 2 seconds. Okay, so it's 133 per second. So that's where that 266 comes from. So really that you're now giving 866. Well, fortunately for you, this machine does not compensate for your circuit compliance, right? And compliance is always in mLs of centimeter water pressure. For numbers' sake, we're going to make it easy and just say the circuit's going to eat up 50 mLs. But if you go higher in pressure, it actually eats more, because if you do mLs per centimeter water pressure, if the patient's getting 20 mLs, it's going to do X, and if you do 40 centimeters of water pressure, it's going to do more, double the volume. So we lose 50 mLs to the circuit compliance, which gives us 816. Now, a fixed gas analyzer like this one, any machine that doesn't have an integrated gas analyzer, the gas analyzer has a pump that's a constant draw. Regardless of whether your anesthesia machine is on or not, it's going to be pulling 150 to 200 mLs per minute constantly. External gas analyzer will then vent into the scavenger. An integrated gas analyzer, like in our Apollo, goes back into the system, so there's no loss from the gas analyzer. So on the bellows-driven non-fresh gas flow decoupled machine, you're going to lose 3 mLs for that breath. Okay? So your patient that's set is 600 is getting 816 on this machine right here with all these variables at 8 liters a minute. Now, just to show you, well, why isn't this more of a problem? They've been using these machines for, 60 some odd years. What's the problem? Well, if you do it at a lower fresh gas flow rate, so if you do a patient, it's the same exact parameters, but at 2 liters a minute, the 2 liters is only going to add 66 mLs to the system, and when you do all your calculations, all the same calculations, it's going to come out to 613. Not so bad. But the time that your patient has trouble, so hypothetically your patient has a pneumothorax, you're going to turn on, your patient starts having trouble oxygenating, you turn up your O's and you go crank it up to 8 liters a minute, now all of a sudden you're giving them more volume and subsequently more pressure, right? So by giving more volume, it's going to give more pressure. So when you look at the piston fresh gas flow decoupled machine, we have the 600 tidal volume that we have over here, but the 8 liters a minute does not affect it because we fresh gas flow decouple. It looks like I work for Draeger here. It says all zeros. Compliance compensation. If you do the machine leak test, the compliance compensation leak test, so you stretch out the circuit, you plug it up, you hit leak test, it's going to account for that. When that is most significant is when you go from a pediatric to an adult to pediatric, because you have a wider range in the compliance of those circuits. Pediatric circuits are made much smaller, so there is less compensation required for it. But if you go through everything, it's 0-0, but then if you do have an external gas analyzer, so we have one machine that has an internal gas analyzer, we have two machines that have external gas analyzers, you will lose the 3 mLs to that. So when you're set at 600, you'll be giving approximately 597, and of course the same goes with our, no matter what your liter flow is, you're going to get the same because we fresh gas flow to couple. And I think the most important thing to take out of here is all the variables that go into your tidal volume. It's not just what I said is what I get on the older machines. It's more on the newer machines. You have more control of what you do. I think the most significant thing is that when you have a patient decompensating, the human body is one of the most dynamic things on earth, and when they get sick. A lot of things start happening within the body. When you start adjusting the anesthesia machine, it starts doing things that you did not intend it to do, and it's important to keep track of those and to account for those when you're making your decisions clinically. So, of course, everything is hyperinflated in the pediatric situation, right? So you have a pediatric patient. I don't need to go over the numbers. We know how I derived them, but we're going to say 4 liters a minute of fresh gas flow, and that's how we do these calculations. On this machine with 4 liters a minute, your fresh gas flow is going to give another 67 mLs. You come down to a 200 set, gives you 232. It's not too bad, but the same thing goes if you double this, if you go to 8 liters a minute, and what's very common in the pediatric population, you knock them down with SIBO, right? So you induce them with SIBO, so you give a high flow rate, a high SIBO concentration rate, and then they go to sleep, they get induced through the SIBO. So it's not uncommon to have a patient on high flows in a pediatric population. So on this machine, you need to be cognizant that when you do that at 8 liters a minute, it's going to change the total volume to that patient to 299 when they're set at 200. So that's a significant increase on those patients. And also when they have trouble, you have to account for it. And of course the calculations are the same for the patient fresh gas flow decoupled. I think some of the things to note in all the variables here are that when it comes to compliance compensation, when you do the machine leak test, at the compliance compensation, you want to make sure that your tubing is stretched out to the farthest point possible, because these are collapsible circuits, and if you leave it the way they come in the package, all constricted, it's going to have less compliance than if you stretch it out to the distance you're going to. So it's nice to know what kind of case and where the patient's going to be in that case. Stretch out the circuit, and it's not, the reason you do that is not for the everyday case. You do that for when that patient starts decompensating. We recommend on the Draeger Apollo that you do the manual leak test, the machine leak test every case, every time you put a new circuit on it. The significance of it, I cannot tell you as a sales rep here, that when people call me up and say, I have a leak in my system, and they didn't do you quantify the leak before they started the case, how do you know where you are if you don't know where you were, right? So you don't know how much you varied from the initial start of the case because you don't know where you were. So I can't emphasize the importance of doing that, because as your patient starts changing what they're showing you as far as the leak's concerned, you need to take all the things and the variables into consideration. What am I doing here? Be able to make your adjustments, but also know where you were to start with. Anybody have any questions on it?
We have to go to Mason.
Yeah.
We've got like a minute.
Speed talk.
Two keywords that we need to talk about: Mapleson D rebreathing. So as you know, there is rebreathing with all the Mapleson circuits. There is no APL valve. There is an APL valve. There are no unidirectional valves. And there is no CO2 absorber. So there is going to be rebreathing in all the circuits, right? The best that came out with it is Mapleson D because of the different configuration of the system, with the fresh gas flow being close to the patient and the APL valve being close to the bag. So there is less breathing in D, which is a modified version of A. So the question may come to identify which Mapleson D variant, which Mapleson circuit is it when you are presented with a drawing, basically. Or the question may come which ways can you minimize rebreathing. Obviously, if you think of how rebreathing occurs, higher fresh gas flows are going to generate less rebreathing, lower tidal volumes are going to generate less rebreathing, and extended respiratory time is going to obviously generate less rebreathing in this particular system. We also need to talk about peak versus plateau airway pressures. So plateau pressure is the pressure that's calculated during no flow. And peak airway pressure is the pressure calculated during the inspiratory phase. So in normal patients, plateau is a good representation of pressures in the lungs, and the peak is going to be barely above the plateau pressure. If you think of what you see on the ventilator. The question is, how do they change, and what's the relationship in between peak and plateau when you have abnormal lung compliance, when you have increasing airway resistance? One instance where none of them change is pulmonary emboli. So there's no change in compliance, there's no change in peak airway pressure. They both go up though when you do increase the tidal volume. So when you increase your tidal volumes, both peak and plateau are going to go up. And they also go up when there is an increase in lung compliance, right? The trend over the abdominal back, abdominal insufflation during laparoscopy, and the Rontal intubation. But they may present differently in other circumstances. So the plateau is going to stay the same. The peak airway pressure is going to go up when you have increased inspiratory flow or when you have an increase in airway resistance. So any circumstance that your airway resistance is going to increase is going to generate a peak inspiratory pressure with a plateau being secretions, kinking, bronchospasm, to name kind of